ඔව් සර් පේනවා.
Right. So let's move on to the next part of neurology. So in this discussion, we are going to do seizures, epilepsy, and movement disorders. Right. Right. Now, the first thing that we have to go through is the definitions of these terms, right? So in this slide, I've just given you the definitions of what a seizure is, what epilepsy is, and what an epilepsy syndrome is, okay? An epilepsy syndrome, remember, has very distinct clinical manifestations. There might be etiology, right? There might be certain changes in the brain structurally that you can detect on MRI, right? And they might have very specific EEG manifestations as well. So this is an epilepsy syndrome, right? So that is something special. But I've also given you the definitions of seizure and epilepsy. Right. Hi. Now, the classification of seizures changes quite often, but something that has sort of been there since 2017, they're trying to revise this again if they have not already done so, by the International League Against Rheumatism, where they define the various subtypes of seizures into focal onset and generalized onset, right? So you have focal onset seizures and generalized onset seizures. And there are some other classes of seizures which are classified as unknown, right? Now, this is sort of the main sort of classification, right, that we use currently. Right, let's start off with the MCQs now. Right. Now, the causes for seizures can change based on age. So if you take the younger people, right, versus elderly people, right? In the elderly, we find that, or at least more than the age of 65, that it's mostly cerebrovascular disease, right? Pre-existing. Make a one damn at the presentation is damn at the
presentation again damn at the
we had it in one daan the okay cut liyaganone maybe.
Hari
පොඩ්ඩක් ඉන්න. sorry. වැඩ 500ක් විතර මේ දවස්වල පමණ. ඒක දාපු ගමන් එනවද ඔයගොල්ලන්ට?
ඔව් සර් දාපු ගමන් එනවා.
Good. Okay. Okay. So if you take text for elderly people, what you find is that the seizures are most of the time you find that these late onset seizures are related to cerebrovascular disease. Now this is different when you have a sort of a younger age group where their seizures are most often idiopathic and probably at the molecular or neuronal channel level. But when you get more elderly, there is ischemic foci in the brain which manifests seizures. So that is true. Okay. Now, that is epidemiology. Another very important risk factor for seizure is penetrating head trauma. Right. So any penetrating head trauma carries a high risk of developing subsequent seizures. That is right. So these are important causes of seizures, and especially in the elderly people, cerebrovascular disease is an important cause of seizures. Now, most of the time, you won't be able to identify a specific genetic cause for seizures. In some cases, yes. But most patients, luckily, you don't have a genetic etiology. There are some very specific seizure types and epilepsy syndromes that can have a genetic predisposition. Now, there are several things that can trigger seizures, right? So sleep deprivation is a very famous seizure trigger. Also fasting, right? And related hypoglycemia can also precipitate seizures, right? So sleep deprivation may precipitate seizures in a right? Okay, so here I've given you some important causes. As you can see, older you get, things like cerebrovascular disease become far more common, right? That's very, very common. Now, when you take the clinical manifestations of a seizure, we'll come back to this EEG business in a minute, right? Now, when it comes to the differential diagnosis of a seizure, a very closely related differential is syncope, right? And in this MCQ, the focus is a lot on vasovagal syncope. So what are the differences between a seizure and vasovagal syncope? Now, this table gives you a comparison between these two disorders, right? So it gives you seizure in the middle and vasovagal syncope on the left and cardiac syncope on the right. But I will just go through some of this in this, some of these points in this MCQ, right? Now, emotional stress prior to the episode is associated with vasovagal attacks, vasovagal syncope. Also, vasovagal syncope occurs in the setting where people have been standing for a long time, they have been in the sun for a long time, right? So that is the sort of thing that triggers off a vasovagal syncope episode. And they classically have this tunneling of vision or a curtain coming down sort of effect on their eyes, right? So that's a very classical symptom that they describe. Right? So the tunneling of vision or something like a curtain falling, right? On their visual fields. That's a sort of classical description that they have. So we were seizure mostly focused on vasovagal syncope. Right. Now, very important to mention that in patients with vasovagal syncope, they may have slight sort of jerky-like movements, which are actually seizures, right? But they're sort of myoclonic sort of jerks, sort of things. I'll tell you why that happens. So when somebody has a vasovagal syncope and falls, right? If they don't fall completely flat, right? If they don't fall completely flat, they can have a little bit of cerebral hypoxia, very transient. And that's why we say never, but it's a somebody has fainted, don't try to lift them off the floor immediately. Because they have, if you try to do that, they'll get a little bit of transient cerebral hypoxia, and that can trigger off a few myoclonic jerk-like episodes. Right? So that is very typical of vasovagal. Sometimes you can get these very short-lasting, transient myoclonic episodes or myoclonic attacks occurring, right? So that's not suggestive of a seizure. More of vasovagal syncope, right? Now, so what are the things that suggest an actual seizure, right? Very importantly is that aura, a well-defined stereotypic aura before the episode might suggest a seizure, right? That's a strong suggestion. They will get this aura, exact same thing every single time, right? Might be something very unusual, or some sort of very stereotype. The word stereotype there is important. Right? So very stereotypical thing that they get. Right, so that is important to mention. Right. Then during the episode itself, right, apart from the seizure, they will have injuries, usually lateral tongue biting, cheek biting is very, very suggestive of a seizure, right? So lateral tongue biting or cheek biting injuries are very suggestive of a seizure. Also, incontinence during the episode, urinary and fecal incontinence is suggestive of a seizure, right? Urinary and fecal incontinence. And another very important thing is, a patient with a seizure will almost always have amnesia to the event. They can't remember what happened. Right? It's a very important point. Amnesia, they won't remember what happened, right? They won't remember what happened. And they are confused, right? Some of them are a bit drowsy and sleepy following it. So post-episode confusion, post-episode drowsiness is very suggestive of a seizure, right? Whereas in a syncope, when they fall, they come back and they can function normal, right? After a few minutes, they'll be back to normal. But after a seizure, they are confused. They have a little bit of sort of disorientation, and they will have this retrograde amnesia. They won't know what happened to them. Amnesia to the event is also a characteristic feature, right? So these are the features that suggest a seizure over syncope, right? Now, before I ask you for any questions from these two MCQs, another important MCQ that we can give you is that we can ask you, okay, what are the features of a pseudo-seizure? Or these are called non-epileptiform attacks nowadays versus a seizure, right? So these are that's another comparison that we can ask you for an MCQ, right? So remember, the non-epileptiform attacks always occur when lots of people are around, right? So crowded places, right? We commonly see this during visiting hours in the ward, right? When people are around the person, right? That's a very characteristic setting in which it occurs, right? And the actual episode is really bizarre and sort of the trash movements, pelvic thrusting, right? Unusual movements, right? And that is very sort of, when it just goes on and on for a long time, right? Yeah. So that's sort of this happening in crowded environments or crowded places, and also this sort of abnormal movements, right? Large volume thrusting sort of movements are very typical, right? Okay, so that's sort of a comparison-like thing when it comes to differential diagnosis for a seizure, right? Okay, all right. Any questions?
Excuse me, sir. Are a genetic
Yes.
predisposition එක මොකක්ද ගත්තේ? I couldn't hear you.
Genetic predisposition එක සමහර අයට තියෙනවා, not most patients කියලා තමයි අපි ඒක කියන්නේ. Yeah.
All right. Right. Thank you.
Right. Any questions? So retrograde amnesia මහින්හා කියන එක ගැන දැන් කලින් වෙච්ච දෙයක් ගැන අමතක වෙනවා. Anterograde is ඉස්සරහට දේවල් මතක නැහැ. They can't form new memories. අලුත් memories හදා ගන්න බෑ කියන එක. Right? Right. Any other questions about these first two MCQs? Okay. Right. Now the next few MCQs are based on some very specific seizure types. Right. So the first thing we talk about is on absence seizures. Right. So absence seizures, as you can see, are a generalized seizure disorder. Right. Now there are two types of absence seizures. One is the typical thing, and there are atypical ones also. We are not going to talk about the atypical ones because they are right. Yeah, we'll come to this fourth statement. Just give me a minute. So there is argument here that aren't metabolic causes the most common cause of seizures. Actually, it is cerebrovascular disease as the ultimate underlying cause. If you take epidemiologically, that is the most common cause, right? Metabolic can also cause seizures, but epidemiologically, cerebrovascular disease is common. Right. Okay. Right. Right. So very specific seizure type is absence seizures, the typical variety. So what happens is this thing that suddenly, this commonly in children you see this disorder. They suddenly sort of go blank for a few minutes and then come back to normal, right? And so there is no motor activity, right? In the typical absence seizure, there is no motor activity. Right? There is absolutely no motor activity associated. Another characteristic feature of this is you can induce it by hyperventilation. That is another important point about these seizures. Sometimes you can elicit them in the clinic when we see these patients. You ask them to hyperventilate, it comes. Right? That is that. Now, typical absence seizures, there are no structural brain abnormalities, right? Absolutely no structural brain abnormalities. Right? So the brain is normal. If you do an MRI of the brain, that is normal, right? But you might be able to see a very specific EEG pattern, which is called the 3 Hz spike and wave pattern, right? So 3 Hz spike and wave pattern when the may wagi appearance, right? Again, not very important to know what it is, but you have to know that this EEG pattern is associated with this particular disorder, right? Okay. So AMCQ එක වැරදි. ඒක හරි නේද? ඒක හරි. Right. So precipitated hyperventilation is correct. 3 Hz spike and wave pattern is characteristic, is true. Right. Now, we'll talk about epilepsy treatment later, but an important thing to remember is you cannot use carbamazepine, right? It actually can make this worse, right? So that is false, right? The most commonly used drug is a drug called ethosuximide. Ethosuximide, that is a recommended drug. You can also use valproate as well, but we'll talk about this later on in a bit more detail, right? Okay, so that's about 8. These are about typical absence seizures. There is another variety called atypical absence seizures, which are not important for you at this stage, right? But the typical variety, there are no structural changes. They just lose their consciousness, right? They don't lose their posture also most of the time, right? And they have this very characteristic EEG pattern. Okay. Any questions about that one? Okay, right. Now, right at the start, we were talking about an epilepsy syndrome. So what is an epilepsy syndrome? An epilepsy syndrome is where you get a very typical story, right? There is a very typical age of onset, right? There is a very characteristic set of seizures that they get, right? There is a very specific EEG pattern, maybe some MRI changes, right? And that's a very nice story. You can build up a nice story. The history is very typical. You have a nice EEG, and it fits beautifully into a single syndrome. So that is what we call an epilepsy syndrome, right? Now, most of your epilepsy syndromes are childhood examples. One of the ones that you can see in adults is called juvenile myoclonic epilepsy, right? Yeah. So remember that absence seizures is a seizure, and absence epilepsy is absence seizures plus other things, right? Plus other things, right? But yes, juvenile and childhood have very similar seizure patterns, right? Absence Rehani, that is, yeah, okay. But remember, seizure and epilepsy syndrome are different. In order to diagnose epilepsy syndrome, you need a certain type of seizure plus other things as well, age of onset and other clinical features. Eye blinking absence is not focal motor activity. You can't take that as focal motor activity, right? Right. Right. Okay. So juvenile myoclonic epilepsy is an example of a epilepsy syndrome. Right. And in that, this is one of the very typical EEG patterns you get in juvenile myoclonic epilepsy. Right. Okay. Right. Another type of epilepsy syndrome you see in adults is called temporal lobe epilepsy. Right? Temporal lobe epilepsy. Right? So in temporal lobe epilepsy, what you see is you see the patients developing seizures which start in the temporal lobe. Right? So these are focal seizures that commence in the temporal lobe. Focal seizures that commence in the temporal lobes. Right? And they might have temporal lobe changes. So the volume of the temporal lobe would be smaller. Right? So remember, epilepsy syndrome kiyanne, you have to have a certain seizure type. There is a characteristic MRI, and there are certain clinical features and age of onset. So everything put, some people have a specific genetic predisposition. You call it an epilepsy syndrome. Right? Right. So in this particular thing, you have temporal lobe volume loss. Right. Okay. Right. True or false regarding temporal lobe epilepsy syndrome is associated with a history of febrile seizures. That is true, right? It's not to say that all people with temporal lobe epilepsy, all people with febrile seizures have temporal lobe epilepsy, but it's an association. It is a strong association. Strong association. Right. Now, what they get, temporal lobe epilepsy, they get very unusual auras. Yeah, more to auras, because it's temporal lobe. Right? The onset is a temporal lobe. So you get very unusual auras, like feeling of fear. Some people have this sort of kalin velati, sort of deja vu phenomenon, right? Sort of very unusual auras, right? So aura is usually absent. In this syndrome, this aura is very unusual, right? Somehow they get very angry and restless and run around the place, right? That could be the aura. So they do get aura, and it's a very unusual sort of weird sort of aura because it's temporal lobe. So it's behavior, perception and behavior is your temporal lobe, right? So aura is usually absent. A typical feature you see in these people is that they have this automatisms like eye blinking, lip smacking features are very, very common, right? So automatisms are a feature. That is true. Automatisms are a feature is true, right? This can include sort of eyelids, sort of fluttering of the eyelids, lip smacking, that sort of thing. Right. So mesial temporal lobe syndrome, they have these temporal lobe seizures. They have unusual auras preceding the seizure, and they have a period of loss of consciousness. They can get automatisms, which are motor most of the time, like lip smacking and eye blinking. Right? And they have temporal lobe changes on their EEG. Nobody is going to expect you to interpret these, but these spiky looking things are the temporal lobe changes. And if you do an MRI on them, some people will also have this volume loss of the temporal lobe. Right? So that is especially in the hippocampal region. This volume loss, you can see that. Right. Now, how do you treat this syndrome? You treat it as you would do a focal seizure. We'll talk about that in a minute. So medication. In people who don't respond to medication, sometimes we do various surgical interventions. Again, not important for you to know what type of surgical interventions. We can do surgical interventions in this, especially for patients who have refractory problems. Refractory disease be an item. We sometimes do surgery on them. Right. Okay, so I'm just going to now put all of this, summarize all of this now, right? So what we've talked about so far is that seizure is a paroxysmal event, and that is a problem where lots of neurons are firing, right, at the same time. Epilepsy is recurrent seizures, right? And these are unprovoked. There is no trigger like hyponatremia or hypoglycemia. An epilepsy syndrome is a broader definition which includes there is age of onset, there is a distinct clinical manifestation, there might be an etiology, genetic changes, EEG, MRI changes. Based on that, I have introduced you to two sort of common epilepsy syndromes that you might get in adult medicine and be asked at the exam in an adult paper, right? So one of the ones would be things like juvenile myoclonic epilepsy or absence epilepsy, juvenile absence epilepsy, which manifests with absence seizures, right? Typical absence seizures. Or something like this temporal lobe epilepsy syndrome, which has a certain set of characteristics. Right. Okay. Any questions from those ones?
So this surgical intervention is indicated in almost any type of refractory seizure, or just
depends on, not in all. There are certain types where you can do surgery, not all. Right? But definitely in temporal lobe epilepsy, we do a lot of surgery in refractory cases.
Right. And so I'm not sure if I'm pronouncing this right. What is this mesial or mesial temporal lobe epilepsy?
Mesial temporal sclerosis.
Mesial.
Again, it's a name for the mesial. It's a hippocampal region. Anatomical term.
Ah, right. Okay.
Yeah. Okay. Good. I have to admit that seizures can have a DMCQ, but you can get one or two of these. You'll see more of these in pediatrics, but they might ask the same things in pediatrics also. So, 1-2 bird, 1 stone sort of thing with these MCQs. Adolescent can go back to adolescent age again, to go to pediatrics, the medicine, right, okay. Now, I'm going to take it back now. Say somebody presents with a seizure, right, for the very first time, right? How would you investigate this patient? Of course, the first thing to see is there a clear precipitant or a provoking factor for your seizure? Clear precipitant or provoking factor, right? Right? So, clear precipitant or provoking factor might be, for example, metabolic derangement or infection. So you do investigations to diagnose that. Right. The next thing to do is an EEG. Now remember, EEG is not a magic bullet, right? It's not a magic bullet. It's not positive in everybody, right? Remember the interictal EEG. What that means is, now if you record an EEG when somebody is just normal without a seizure, right? That can be normal in up to 60% of people. So people who actually had a seizure, they might have a normal interictal EEG, right? 60%. So just because the EEG is normal when the patient doesn't have a seizure, that doesn't mean it's not. They have not had a seizure. So remember, the interictal EEG, right, can be normally about 60% of the people. So remember, that's why we always say that when you're diagnosing a seizure, the history is very important. The eyewitness account is very important. And also nowadays, the camera phone recording. Many people do this now. They record it on their camera phones, and that is very important, right? More than your EEG. Of course, you can do something called a video EEG or even an ictal EEG, which will obviously show you the changes while the patient is having the seizure. And you can see with the video as well. But we don't do that in everybody because of this resource limitation. You do those in the difficult cases, right? Difficult cases. You might do something like a video EEG, right? Right. And then, so that is the answer to that question. EEG එක මුලින්ම පළවෙනි ප්‍රශ්නේ තිබුණ එකක් නේද? මම ඒකත් ආවට EEG is abnormal in most patients. මෙතන හදාගන්න මේ interictal EEG කියලා. ඒක නැත්නම් එච්චරම හොඳ statement එකක් නෙවෙයි, interictal EEG. So I'm referring to the interictal EEG කියන එක. Right? So most patients with epilepsy or seizures, their EEGs are normal, right? Interictal EEGs are normal. Right. Now, finally, if you are suspecting a patient with an epilepsy syndrome, right, then of course you will look for MRI changes, right, and very specific things as well in the imaging, right. Okay. Right. So this is how sort of investigations for somebody who has had a first seizure and comes to you. So history and examination is very important. Eyewitness account is very important. Video observation, if there's a camera phone recording, is very important. Remember the EEG, if you just do an EEG on a normal person who doesn't have a seizure at the moment, it will be normally about 60% of the people. Right. Okay. Kanishka, so when we say that temporal lobe epilepsy association with seizure, so if you look at people with temporal lobe seizure, ask them, have you had a family past history of epilepsy? Most of them will say yes, there's a strong association. Right? It doesn't causality, there is an association, right? So in your epidemiology statistics, they would have taught you about this sort of thing, right? Okay. Right, now we go a little bit more in depth into treatment of seizures and epilepsy, right? First statement, okay, now we just talked about a patient who has had one episode of a seizure, right? So we have investigated this patient and we've said, okay, this is a true seizure, right? And we do all these investigations also. Right, do you start anti-epileptic drugs? Right, that is a very controversial question, but currently, usually not. Right, so after a first seizure, we don't usually start the patient on anti-epileptic drugs. Right? Because actually, the risk of that fellow having another seizure is actually very small. Right? Right? They have had one seizure, true. But තව එකක් හැදෙන්න තියෙන chance එක ඉතාමත් මදි. Right? So they don't need any treatment. But there are exceptions to that rule. We sometimes do start anti-epileptics following the first seizure in these indications. Number one, right? Most of the time, no, but there are certain exceptions, right? Because most of them know why, because they never have another seizure again, right? That is what the data shows us. Studies in. But we do start it in these very specific situations. Number one, if they are doing some sort of high-risk job or they want to get back to a job where they're in danger, right? If they had a seizure, they'll be in major trouble, right? We start them on treatment. Right. Okay, that is one, right? Number two, if there is a clear evidence of an epilepsy syndrome, right, where they have MRI changes, they have some genetic mutation positive, then you know they are going to get another seizure. Risk of recurrences are much, much higher. So if you can clearly identify somebody has a epilepsy syndrome, you should put them on anti-epileptic, even after one seizure, because their risk of recurrence is very high. MRI එකේ අවුල් තියෙනවා නේද? ඔය වගේ ප්‍රශ්න ගොඩක් තියෙනවා. Right. That's indication number two. And also you should consider anti-epileptics even after one seizure if there's a clear structural abnormality in the brain. There you know, මෙතනින් තමයි මේ seizure එක පටන්. This is where the focus of this seizure. If somebody has a massive infarct and develops a focal seizure, then again they are at a high risk of developing another one because that's there, that focus is there. Right? So that is the third instance where we might give anti-epileptics after a first seizure. So one is if they want to send them back to a high-risk job in a few months' time, right? So you want to stop them from getting any further seizures, right? Some person who has a clear epilepsy syndromic diagnosis, yes. Or if they have a structural lesion in the brain, yes. So these are the indications for seizure after first seizure anti-epileptics. Right. Monotherapy is preferred is true. The recommendation is when you are starting anti-epileptics, start with one, right? One drug at a time. Monotherapy is preferred. Monotherapy is preferred. Right. So what anti-epileptic drugs can we start? Right. So this is a list of the recommended anti-epileptic drugs based on type of seizure. Right. So based on type of seizure, these are the list of anti-epileptic drugs. Right. Yeah, somebody's doing EEG after first seizure. Yes, that's what I told. In the investigation, you do an EEG, but even if it's normal, you can't completely exclude a seizure. Family history එකක් තිබුණ පළේට anti-epileptic drug දෙන්න ඕනේ after one seizure, unless there's a clear sort of family sort of syndrome, epilepsy syndrome diagnosis, right? Seizure imaging, MRI is the best, right? Not CT scan, right? But because resource limitation, right? You might do a contrast CT or something. No point in doing a plain CT scan. Right. So looking at anti-epileptic drugs, you can see that in focal seizures, right, we commonly use drugs like carbamazepine, oxcarbamazepine, right? These are mostly used. In generalized seizures, there is a tendency for us to use a lot of valproate, lamotrigine. These are two very commonly used anti-epileptics in generalized seizure types. Valproate ගැන. Of course, in the UK, you cannot give valproate to females of childbearing age, right? That's a big no-no. It is, you can't give it essentially, right? To females of childbearing age because of the high teratogenic potential, right? ලංකාවේ නම් වෙන බේත් නැති නිසා අපි දෙනවා, but then you have to talk to them a lot about family planning and contraception, right? But it's better to keep a female off valproate if you have other drugs, right? A female of childbearing age. So lamotrigine would be a good choice, right? And most parts of the world, the first line drugs are sort of lamotrigine තමයි ගොඩක් අය දෙන්නේ, and especially for females, right? So that is important to remember that, right? Okay. And most of the anti-epileptics are sort of act on inhibitory neurotransmitters. Right. Okay. Right. Right. So juvenile myoclonic epilepsy, again, we do not use carbamazepine. It's a generalized seizure disorder, and actually carbamazepine can make it worse, right? Again, you can use valproate, but we use a lot of benzodiazepines in juvenile myoclonic epilepsy specifically, right? Benzodiazepines පාවිච්චි කරන්නේ ගොඩක් වෙලාවට. Okay. All patients can be weaned off antiepileptics after a seizure-free period of 2 years. Now, whether all කියපු නිසා වැරදි, again, the point here is that if you have a patient with an epilepsy syndrome, they will probably need anti-epileptic drugs for life, right? They will probably need anti-epileptic drugs for life, right? For example, a good example is juvenile myoclonic epilepsy වල කවදාකවත් anti-epileptic නවත්තන්න බෑ ගොඩක් වෙලාවට. දිගටම දෙන්න ඕනේ, right? So, this all patients කියන නිසා මෙතන වැරදි. Right? Okay. So valproate එක බොරු කතාවක්, මේක වැරදි. You can't give it to childbearing age females because of the teratogenic effect. So Sasani is asked, what are the most least teratogenic drugs? So carbamazepine, oxcarbamazepine have very low teratogenic potential, right? Very, very low. And some of the newer ones like lamotrigine, levetiracetam also have very low teratogenic potential. So valproate, that is the problem, right? That is the problem. Phenytoin also is a big problem, right? But some of the newer things like lamotrigine, levetiracetam, right? Carbamazepine, oxcarbamazepine, even though it's old, they are very safe in pregnancy, right? Vigabatrin අපි සාමාන්‍යයෙන් adults ලා පාවිච්චි කරන්නේ නැහැ, කලාතුරකින් තමයි සසුදු පාවිච්චි කරන්නේ. Right. Okay. Any questions?
Sir, when you're selecting a first-line drug, how is the ideal process? Is it that now your table has a lot of first-line drugs now? So out
so
of
you have
that,
the freedom of using anything you want in that list. Yeah. But it all depends on things like drug availability. So things like carbamazepine and valproate are freely available in the government sector in Sri Lanka, right? So we commonly prescribe them. But the valproate is a big problem in childbearing age females, right? So ඒකට lamotrigine වගේ ඒවා දැන් හොයාගන්න අමාරුයි. Some especially neurology units වල තියෙනවා, but it is not everywhere in the country, right? But this is all the options that you can use කියන එක මේ කියලා දාලා තියෙනවා. Yeah. But then you have other patient factors, drug availability, lots of things that come into play as well.
Right, sir. And also, so this the patients who need lifelong antiepileptics, you mentioned seizure syndromes. වෙන මොන හරි තියෙනවා?
ගොඩක් වෙලාවට ඒක තමයි most of the time it's for these epilepsy syndrome people, right? In all other people, if they have not had a seizure for at least a year, better 2 years, at least a year, you can start tearing off or weaning off their antiepileptic drugs, right? But if you have epilepsy syndrome, it is not a good idea to do that, especially things like JME, juvenile myoclonic epilepsy. There's a high risk of recurrence when you stop it. Right? So they most often need very long to get our treat කරන්න වෙනවා.
Right, and also is there a time limit to like not drive and is something you need to know?
Yeah, so in Sri Lanka, there are no specific, as of most things, there are no specific rules. Like UK වල හරිම specific rules තියෙනවා with driving කරන්න පුළුවන්. I guess each type එක අනුව වෙනස් වෙනවා. කොච්චර කාල drive කරන්න පුළුවන්ද බැරිද කියන එක. හරි? The ලංකාවේ කහන්න බෑ because there are no rules, right? So I don't think they'll ask you that because there are no specific rules. එහෙම නැහැ. Yeah, so I don't know the answer to that question because I don't think there are any specific rules written down anywhere in Sri Lanka for driving, right? But generally, for all means and purposes, 6 months, yeah, reasonable time frame. Yeah,
right. Thank you.
Sir, as JME is treated for lifelong, the benzodiazepine, is it given for that much duration?
පොඩි සමහර අය දෙනවා, but you can give alternate drugs like lamotrigine වගේ valproate වගේවත් දෙනවා. හරි? Yeah, I Shamal get a similar question.
Excuse me, sir.
Yes.
Sir, is there an indication to give lifelong therapy for high risk jobs, sir?
Again, depends on the context. So they are not going to do the high risk job for everyone, right? So again, depends on the context and patient factors. There is a specific recommendation I can't give. Yeah.
Okay, sir. Thank you, sir.
Right. Again, Kusal, the sort of questions you're asking in if there's a big sort of infarct or something, can you stop it? It all depends. These sort of questions are very difficult to answer. Right, very, very well. And they're most often, there is no evidence behind it also. It's sort of an individualized, personal preference sort of management that goes on. Yeah? A specific guideline එකකුත් නැහැ වගේ දේවල් වලට. And definitely they will not ask these MCQs. Right. Okay. Right. Now question number 6 is focusing on adverse effects of antiepileptics. Right. Now, Stevens-Johnson syndrome is a very famous. Somebody අහලා දිනවා carbamazepine generalized seizures වලට දෙන්න බෑ කියලා පුළුවන් but first line drug එකක් නෙවෙයි, right? It's not very effective, more effective for focal seizures. Right, true or false regarding the adverse effects of antiepileptic. Lamotrigine, yes. Stevens-Johnson syndrome, well known to cause it, right? Well known to cause Stevens-Johnson syndrome. The other common association is carbamazepine. Right, that's the common association of Stevens-Johnson syndrome. Right. Valproate can cause pancreatitis. මම මෙතන list එකක් තියෙනවා. Yes. ලොකු list එකක් තියෙනවා. මේක නම් කොහොම පාඩම් කරගන්න බෑ. But just skim through this list. Right. එතන මේටික් හරිය ඔක්කොම Stevens-Johnson syndrome, pancreatitis. But remember, valproate, the main problem is teratogenic, very high teratogenic potential. Carbamazepine, SIADH, hari, right? Phenytoin causes a lot of sort of coarsening of facial features. Gum hypertrophy is very well known with phenytoin, right? That's true. Topiramate, but weight loss එකක් එන්නේ. Topiramate, not weight gain, weight loss. Actually, a lot of these anti-epileptic drugs cause weight gain, right? But topiramate causes weight loss. Right, topiramate causes weight loss, so that is wrong. Right. Right. So people have asked about prophylactic anti-epileptic drugs. Currently, the use of prophylactic anti-epileptic drugs is very, very limited. We very rarely use prophylactic anti-epileptic drugs. After strokes and so very rarely. Right. Yeah, so toxic epidermal crisis and Stevens-Johnson syndrome are part of that same spectrum of disorders, right? And yes, carbamazepine, lamotrigine, both can cause that as well. Yes. Good. So that's all about anti-epileptic drugs and seizures, epilepsy. I have to say it's not very common to get MCQs on these for medicine, but you will get some questions for pediatrics. So currently we have gone through headache, cerebrovascular disease, now seizures and epilepsy, and now we go on to movement disorders. And the whole other bulk of the neurology is in those other two presentations which we'll do on the weekend. They presentation that's a lot of clinical neurology, so we cover all the rest in those two sessions. Right? Okay, I hope you have done that. Presentation there is no paper for that. Huh?
No, sir.
Okay, good. Right, so now we move on to movement disorders. Right? Now, if you take all the movement disorders in the world, there are two big groups that you can classify them into. Right? On one hand, you have increased movement in hyperkinetic movement disorders. Hyperkinetic movement disorders. Right? Or you can have hypokinetic, or some people call it akinetic rigid syndromes, or hypokinetic disorders. So you have hyperkinetic disorders and hypokinetic disorders. Right. Hyperkinetic disorders examples are tremor, chorea, athetosis, tics, right? Hypokinetic disorders are akinesia and rigidity. And you have clearly defined diseases and syndromes that manifest these movement disorders. Parkinson's is rather special because it can have both hypokinetic features as well as hyperkinetic features. Right? But of course, things like Huntington's will be clearly hyperkinetic movement disorders. Right. So having talked about that introduction, so the main classification into hyperkinetic and hypokinetic, let's now move on to discuss a little bit more. So let's talk about Parkinson's. But a vinadiya then the problem into Pantiak Karnako, they got the current product in there. Meeting about a point of I'm going to message them. Okay, right. Now, what we're going to do is we're going to talk about Parkinsonism now. Now, Parkinsonism is a collection of symptoms and signs. Parkinsonism. Right. Now, Parkinsonism consists of, right, the classical signs and symptoms would be tremor, right? The tremor is a resting tremor, and we talk about this a little bit more in MCQs, right? Rigidity, akinesia, and postural instability. Tremor, rigidity, akinesia, and postural instability, right? That is the syndrome of Parkinsonism. That is the syndrome of Parkinsonism. Okay. Now, that syndrome of Parkinsonism can be secondary to various things. various other disorders. And I've given you a long list of things, but I would like to highlight vascular disease. Right? This is called vascular Parkinsonism. Some people call it vascular Parkinsonism. Right? Then you can get secondary Parkinsonism due to medications. You have seen this a lot when you go to the psychiatry wards. So these are secondary causes. These are secondary causes. Okay. Then, on the other hand, you have primary disorders. There is no specific etiology there. They are primary disorders. Within that spectrum of primary disorders, you have idiopathic Parkinson's disease, IPD, the very classical idiopathic Parkinson's disease. But you also have a set of disorders which are in this big box here. These are called atypical Parkinson's. Atypical. Some people call this Parkinson plus syndromes. Parkinson plus syndromes. They have a little bit of odd presentation compared to idiopathic Parkinson's disease. We'll talk about a little bit of this as we go on in the MCQs. So this is your class. You have a syndrome of Parkinsonism, which is characterized by tremor, rigidity, akinesia, or bradykinesia, and and you have primary manifestations of this, or secondary due to various other disorders. In the primary, you have the very classical textbook idiopathic Parkinson's disease that is very, very common. But you also have this sort of second atypical Parkinsonism or Parkinson plus syndromes, which are slightly unusual characteristics. Right. Now let's talk about idiopathic Parkinson's disease first. Now, in idiopathic Parkinson's disease, pathologically, you have these structures which we call Lewy bodies in the substantia nigra region in the brain. These are called Lewy bodies. What actually happens, and these are all for you to read, I'm not going to read this sentence by sentence, but listen to what I'm just explaining this. So in Parkinson's disease, you have a loss of dopaminergic neurons. That is important, right? That in the substantia nigra, which is a part which is predominantly the basal ganglia and midbrain region, or it is mainly midbrain region, but also the basal ganglia, right? And typically you get these Lewy bodies. If you cut open a brain in somebody with Parkinson's, you get these typical Lewy bodies seen. And this we talked about. Right. Karala metana me, yeah. Or Lewy bodies actually in alpha-synuclein substance, which is supposed to be very important in the pathogenesis of the disease. There's a lot of research going into that field now. Now, people are doing research on this. Right. So, alpha-synuclein is critical to the pathogenesis. That is what people believe. That is true. Parkinson's, I told you, is a loss of dopaminergic neurons in the substantia nigra, and you see these alpha-synuclein aggregates, we also call them Lewy bodies in the substantia nigra. Right. Now, in idiopathic Parkinson's disease, they have tremor. Tremor. What are the features of this tremor in idiopathic? They make it idiopathic decay. The first tremor is a rest tremor, no doubt, no problem there. It is a rest tremor. And people describe it as a pill rolling tremor. Sure, Professor Chang has shown you videos of this in his lectures. It is some beautiful lectures on Parkinson's. Today you see this pill rolling tremor. Pill rolling tremor. Now, this is very important. Remember, in idiopathic Parkinson's disease, this pill rolling tremor starts off unilaterally. Right? Unilaterally then becomes bilateral. Bilateral. Right? An important thing you need to remember is it is almost always asymmetrical. So it starts off unilaterally, right? Spreads bilaterally, but is usually asymmetrical. Asymmetry. Right. So typically presents with bilateral symmetrical can be bilateral, but is asymmetrical, not symmetrical. That is very important. So idiopathic Parkinson's, they have a pill rolling tremor, starts off unilaterally, goes bilateral, but is asymmetrical, right? And rigidity, traptake rigidity is usually we describe this as a lead pipe rigidity, which where the rigidity is present throughout the range of motion, throughout the range of movement. Clasp pipe rigidity is more of a upper motor neuron sort of sign, a spasticity. So make us Baradi, this is lead pipe rigidity. And sometimes you can feel this lead pipe rigidity superimposed with the tremor. Cogwheel rigidity. Cogwheel rigidity. Right. So they have TRA, bradykinesia or akinesia, where the movement is a paucity of movement, slowness of movement. And finally, postural instability. Now, apart from these very typical motor manifestations, there are lots and lots of non-motor manifestations in Parkinson's, idiopathic Parkinson's disease, whether lots of non-motor manifestations. Goda localized to appear, right? Localized to appear. Sleep disorders, memory problems, then autonomic problems, right? Autonomic urinary issues, bowel issues, right? Lots of things. Some are lots of taste, maybe smell, lots of non-motor manifestations. And actually there is research to show that these non-motor manifestations actually precede the motor manifestations. Dementia නෙවෙයි, මම dementia ගැන විනාඩියෙන් කියන්න. But these GI, urinary, sleep disorders, can precede the motor manifestations. They are culling in them. And sometimes 5 years before, right? That's what we are identifying now. This has been known for a long time, but it's very clear in the evidence, right? Very clear in the literature that non-motor manifestations can precede the motor manifestations in idiopathic Parkinson's disease. Right. So that's a little bit about the little bit about the sort of manifestations and pathogenesis of Parkinson's disease. Any questions about this? Right. Okay. Now, in this classification, we talked about something called atypical Parkinson's or Parkinson's plus. Who likes to appear? So, clinical features mataka tiyaganna ඕනේ නැහැ. මම පොදුවේ කියන්න. Right. Now, මේක life to වගේ ලියාගත්තත් කමන්නේ මේක අහන දෙයක්. So, there are certain things that can suggest atypical Parkinson's. Any of these things. මේ ලොකු life to අපි මෙතන කියන්නේ. අමුතු features. මේ අමුතු features ටික කියන්නේ. So these are the features suggestive of atypical Parkinson's or Parkinson's plus syndrome. Number 1, early onset dementia. Now this is very important. MCQ ගහනකොට බොහොම පරිස්සමෙන්. Parkinson's disease patients, even idiopathic Parkinson's disease, after a certain period of time, they get dementia. හැබැයි මෙහෙම එකෙම නෙවෙයි. Dementia is the presenting feature, right? So in atypical Parkinson's or Parkinson's plus syndromes, one feature could be early onset, which is not suspecting. When early onset dementia, where dementia starts before the other things, that is number one, early onset dementia. Right. Okay? Right, that is number 1. Early onset dementia. Right. Okay. Next one. Significant autonomic symptoms. Significant autonomic symptoms. Especially things like postural hypotension. Right? Significant postural hypotension. Autonomic symptoms. Again, a feature of Parkinson's plus or atypical Parkinson's. Right? Autonomic, predominant autonomic syndromes. Right. So, early onset dementia, autonomic syndromes. And these autonomic syndromes cause recurrent falls. So presentation with recurrent falls. Presentation with recurrent falls. That is the presentation. Idiopathic Parkinson's I but they have other these people with Parkinson's plus common features. So one is early onset dementia, number two is very significant autonomic manifestations like postural hypotension features, right? Then there are recurrent falls as the presentation of the disorder, right? Next one, involvement of other parts of the nervous system. So you know that all these Parkinson's disorders affect the extrapyramidal part, but involvement of the pyramidal system, involvement of the cerebellum. So maybe other parts of the nervous system are involved. That is another feature of atypical Parkinsonism or secondary Parkinsonism. Right. Hatarak kiwa then. Paha. Gaze palsies. If they have prominent gaze palsies, especially vertical gaze palsies, that is also another feature of atypical or Parkinson's plus syndromes. Hari? හරිනේ ඒ ටික දැන් මේ කියන්නේ මෙන්න මේවා වල common features ටිකක්. ඔකට undergraduate level එකේ common features ටිකක් මේ කියන්නේ මතක තියාගන්න. Right? So early onset dementia, autonomic manifestations, recurrent falls, vertical gaze for other parts of the nervous system involved, like things like the pyramidal pathways involved, the cerebellum involved, all of these. One last thing is that idiopathic Parkinson's responds beautifully to levodopa. At least for a short period of time, it will work, right? Very well, right? And they sometimes have dyskinesias also. Over movements and levodopa dipugama. In the atypical Parkinson's or Parkinson's plus syndromes, the responsiveness to levodopa is poor, right? That is the point you need to remember. Okay. And finally, Parkinson's plus syndromes, they have very characteristic MRI changes. Amutu MRI changes ටිකක් තියෙනවා. මම ටික පෙන්නන ආසාවට උඩට බලන්න. Right, so let's test our knowledge in this question number 8. Early postural so idiopathic Parkinson's, idiopathic Parkinson's. When you say Parkinson's disease, we are referring to idiopathic Parkinson's disease. I have to say that. Early postural instability indicates an alternate diagnosis is true. Right? That's a feature of Parkinson's plus or atypical Parkinson's. MRI demonstrates significant mid-brain atrophy. So structural brain changes are typically seen with this atypical Parkinson's or Parkinson's plus syndromes. So examples hummingbird sign. Hummingbird sign. This is called a hot cross bun. The Christians will know what a hot cross bun is. If you don't, please refer. Hot cross bun sign. Hot cross bun sign. So there are MRI changes, which are associated with secondary Parkinson's plus syndromes. Right. Okay. Now, up to now, we have not had much success, or at least effective drug for disease modification. Now, in rheumatology, we talk a lot about disease modifying drugs, which limit the progression of disorder. Unfortunately, none of the drugs are actually effective at modifying the disease progression, unfortunately. Some drugs, people think they might, but most of the drugs are absolutely useless at modifying the disease progression, right? There is one drug called, but essentially, for your level, none of the drugs are effective at modifying the progression of the disease. So how do we treat Parkinson's? Right? There are several drugs that we use, right? certain drugs that we use. I've given you a table of the important MCQ වලට අහන જાතියේ මගුල් ටික මේකේ දාලා තියෙනවා. Now, whatever it is, levodopa is very effective, right? And we usually combine levodopa with decarboxylase inhibitors to break down, make sure that the drug is intact as when it reaches the brain. Because some can be broken down in the gut. So to avoid that, we give them these decarboxylase inhibitors, right? A major problem with levodopa is that they can cause a lot of side effects, gastric, and also this dyskinesia, increased movement, right? And they're very good at treating bradykinesia, right? Very, very good at treating bradykinesia. Right. On the other hand, anticholinergics are very good at treating tremor. Right? Anticholinergics are good at treating tremor. Right. Okay. Now, there is also a big group of drugs that we use in Parkinson's, especially as early therapy, and these are your dopamine agonists. Right. Ropinirole, pramipexole වගේ drugs පාවිච්චි කරනකොට අහලා ඇති dopamine agonists, right? And these are probably given as early therapy, as monotherapy, or in combination with levodopa. It's details ඔයගොල්ලෝ දැනගන්න ඕනේ ඒවා therapeutics of Parkinson's, you don't need to worry about, right? But these are used as early therapy. Levodopa you can use it anytime, right? But dopamine agonists are most effective in the early stages of the disease. Now, there are some unusual side effects that we love to ask for MCQs, especially dopamine agonist ගත්තම impulse control disorders එනවා, hallucination. කියන්නේ gambling වගේ impulse control problems එනවා. These people get gambling issues. They are control impulse is the problem. And they can get very unusual retroperitoneal fibrosis with some of these medications. That's a rare side effect. It's a rare side effect. Hi. Then, of course, you have things like COMT inhibitors, MAO-B inhibitors, selegiline, rasagiline. Again, early mild disease. Okay, this rasagiline might have a little bit of a disease-modifying action, but people, there is no, the effectiveness, right? So, but that's what some of the trials have shown. Right? So, this is your sort of the drugs that you can use for treating Parkinson's. අපි මේක ආයෙ මතක් කරමු MCQ කරන ගමන්. අනේ මෙතන මේක complete නැහැ. paper එකේ මම දන්නේ complete ද කියලා. anticholinergic paper එකේ මොකක්ද තියෙන්නේ? මට මතක නැහැ ඒකේ මොකක්ද තියෙන්නේ කියලා. දෙකේ තියෙනම anticholinergics කියලා විතරයි තියෙන්නේ.
ඔක්කොම තමයි සමයි.
මේකම තමයි හරි. ඒතර ඔයගොල්ලෝ කැමති එක ලියාගෙන ඒක හරි දාගන්න. So anticholinergics, the important point is anticholinergics are very good at treating tremor. Whereas dopamine drugs are very good at treating bradykinesia, especially the dopamine, levodopa වගේ දේවල් වලින් bradykinesia treat කරන්න පුළුවන් හොඳට. ඒතර ඒක මොකක් හරි එකක් විතර දාගන්න. Impulse control disorders, ඒක මම කියවන අහනවා කියලා gambling is that's a very famous MCQ. They ask about dopamine agonists in Parkinson's, and this is true, it really happens. When you give them මේ සුර පිස්සු හැදෙනවා, gamble කරනවා, අස්ස රේස් දාන එක එක අමුතුම සෙල්ලම් කරනවා. When you say REM sleep behavior disorders, REM sleep or psychiatric REM sleep behavior disorder, dopamine agonists. Right. So these are some important MCQs that you need to know. Right. So I told you that dopamine agonists are possibly in younger patients, initial therapy on that, right? And levodopa is effective usually at any stage of the disease. But as the disease progresses, the time that it is effective gets short and short. If there are 8 hours that it gave the effect, now it might give you only 2 hours of effect. Right? That's the disease progresses. But things like dopamine agonists, MAO-B inhibitors, they are mostly early disease effective, but then later it becomes not very good. Right. Right. Any questions about Parkinson's?
Sir, second stem, sir.
මේකද?
Aim.
නෑ. අටේ.
Oh, කලින් question. Oh, කලින් question.
හතේද අටේ?
අර mid brain atrophy. Okay, sir.
මේක.
MRI demonstration. mid brain atrophy කියන එක sir ඒක කියන්නේ
significant කියන වචනේ නිසා තමයි වැරදි යෝග.
okay.
හරි?
එතකොට sir මේ idiopathic
ගොඩක් වෙලාවට idiopathic Parkinson's MRI එක normal. පොඩ්ඩක් ඔය හෙම්බලින් පොඩ්ඩක් atrophy තියෙන පොඩ්ඩක් නමුත් ගොඩක් ගන්න normal. තාම වෙනම scan එකක් කරනවා dopaminergic neurons බලන වෙනම scan එකක් කරනවා ඒක ලංකාවේ කරන්නේ නැහැ.
Okay. සර් එතකොට අර හොඳට අර මේ dopamine අර stain එක අඩු වෙලා පේන්නේ postmortem එකේ
ඔව් ඒ කියන්නේ ගොඩාක්ම advanced diseases වලින් also Parkinson's plus syndrome වලත් you can get midbrain disappearance you can get in certain disorder Parkinson's plus disorder එකක MSA කියලා. එතකොට ඒකේ හොඳටම midbrain එක atrophy වෙලා තියෙනවා. But actually idiopathic Parkinson's උච්ච atrophy වෙන්නේ නැහැ.
Okay.
Can they get non-motor symptoms with dopamine? So non-motor symptoms කියන්නේ මේ මොනවද GI යනමනේ ඒ වගේ problems එන්න පුළුවන්. Yes. With dopamine agonists. Yes. And this REM sleep behavior disorders, gambling, impulse control problems, ඒව තමයි ගොඩාක් එන්නේ side effects. So non-motor side effects තමයි ඒවා. Yes. Right. Okay, right. And then we talk about the other. Question number 9 is on the other sort of hyperkinetic disorders. මේටි ඔක්කොම හරි. හරි. කොරියා වලට මම ලයිස්තුවක් කොහේ හරි දීලා තියෙනවා කියලා මතක නැහැ නේද? හරි. මේටි ඔක්කොම හරි. Right. So rheumatic fever in Korea, you have heard of synonyms Korea කියලා කියනවා. Right. Okay, good. But now the last one is about essential tremor. Right? Essential tremor. And this is very, very important. Right? How you would differentiate essential tremor, right, from Parkinson's tremor. Now, the important point about essential tremor is that it is an action tremor, right? Whereas Parkinson's is a resting tremor, right? And an important unusual thing about essential tremor, alcohol buerma නැති වෙන. හරි alcohol buerma නැතර අපේ batch එකේ හිටියා උට essential tremor තියෙනවද කියලා බලන්න කට්ටිය පාරුට පොවන්න හැදුවා. I don't know whether that experiment succeeded or not. But yes, so alcohol buerma tremor එක අඩු වෙනවා. And also essential tremor අයගේ voice එකත් පොඩි tremor එකක් තියෙනවා. ඔළුවත් පොඩ්ඩක් හෙල්ලෙන ගතියක් තියෙනවා. Parkinson's all you can get this jaw and chin lip tremor එකක් එන්න පුළුවන්. But that's not very prominent. In essential tremor they get a theta base, that is a clear head tremor එකක් එනවා. Right? That is another important difference. Right. Now let's go to the MCQ and we'll explore this a little bit more, the differences. Right. Essential tremor is autosomal dominant inheritance. Right. There is autosomal dominant inheritance. Right. මේක පොඩ්ඩක් චෙක් කරන්න මම මතක නැහැ දැන් ඇඩොලසන්ස් ලගේද වැඩි කියලා. ඕගොල්ලෝ දැන් විභාගේ ලෑස්තිද ගවන්නේ? හරිද මේ? මට මතක නැහැ දැන්. This epidemiological details, who can remember me? Right. Just find that out if you don't know that. Right. Now, essential tremor can present with a rest tremor, like an action tremor එකක් විදිහට present වෙන්නේ. Is alleviated with alcohol, that's true. And the commonly used drug, yes, 40 years කියලා කවුරු හරි කියලා තියෙනවා. Yes, that's true. Yeah, so this is very good. Propranolol. So one of the important drugs we use for essential tremor is propranolol. Right? Propranolol දෙන්නේ. But you can also use topiramate is also very effective for essential tremor. That's kind of a thing, yeah. Topiramate. Hi. Okay. ඒ දැන් ඒ දෙක මම මොකේද වැඩි කියලා තමයි හොයාගන්න ඕනේ. ඔක මොන age group එකේද වැඩි කියන එක. There are two peaks, but what age group එකේ වැඩිද කියන එක තමයි පොඩ්ඩක් බලන්න. මේ මට මතක නැහැ statistics මේ epidemiology එක මතක නැහැ දැන්. හරි. Okay, so best response MCQs. Right. Okay. So both on pregnancy. Let's do the second one first. All right. Second one first. 18-year-old female, 12 weeks into an unplanned pregnancy, and has been diagnosed and on valproate. Unfortunately, valproate දෙනවා ඉතින් ලංකාවේ වෙන බෙහෙතක් නැති නිසා for these patients. Unfortunately, that is a problem, right? So what are the following is correct concerning this patient? You know what I mean? So there is an increased risk of neurotube defects in the fetus is true, obviously, right? That is obviously true, right? මේක එකපාරට දැන් valproate කියලා නැවතුවා කියලා වැඩක් වෙන්නේ නැහැ. right? එකපාරට valproate නැවතුනොත් එන seizures වැඩි වෙනවා නේ. So this is a very difficult situation. You'll have to accept that there is a risk of this patient developing neurotube defects, right? You can't suddenly stop the valproate now. Then ගියා ගොඩක් හර the critical period of organogenesis multica. So that is a big problem, and you can't do anything else. What you might do is maybe put in another safer drug and try to take the valproate off very slowly, but that needs specialist input. Where a party can trigger seizure. Remember, pregnancy where a seizure is very well. Right. Okay, and what are the important drugs that cause hair loss? So valproate per day, the problem is you get a lot of hair loss, and also you get sometimes hirsutism because of tender valproate. Hirsutism godak ferrito inverter, right? So valproate can cause that problem as well, hair loss. Right. So unfortunately, even though in many countries around the world, valproate is practically banned in people who have women of childbearing age, because we don't have any other alternative. We sometimes have to give it to women of childbearing age. But you have to talk about contraception. If you have anything else, perfect. Lamotrigine වගේ තියෙනවා නම් ඒක දෙන්න. Please don't give valproate. Right. Okay, so that's done. SCQ එකක් තියෙනවා epilepsy ගැන එකක්. And we will try to do one session of SCQs where we sort of talk about one or two of these and just get you into the habit of writing a few.
Sir, sir, කලින් class එකේ SPR ටික ඉතුරු ඉස්සර මම හිතන්නේ you had a meeting or something, I think. එදා කලින් ඉවර කරාද කොහෙද? Hello?
හරි. පොඩ්ඩයි. Right. ඒකත් කරමු. So let's finish those off. Pen or screen?
Oh, sir.
Okay. So I told you that these are easy now, easy to answer. We've discussed this. So make a subarachnoid hemorrhage, right? So what would you do here? Here no bad? Yeah. So based on that rule I told you, I can now sometimes in these best response MCQs. So Supun, I told you that's a very dodgy thing. Now your argument is, is it sensible to continue the valproate, right? That is a specialist decision, right? There are two options. Either you crack on with the valproate and give it, then which they would not or you can very carefully come off it and give a much safer non-teratogenic drug for seizure control. That all depends on the person who's managing. There is no evidence for these sort of things. Right? Yeah, so that's a very difficult specialist level decision. Even we wouldn't, as consultant physicians, general physicians, we would refer to neurologists to sort it out. Right? It's a very difficult decision. Yeah, and needs specialists. You need a specialist for some things. These are sort of things you need them for. Right? Okay, now, right, the patient should never have been on valproate in the first place, but that's a different argument. So, Rehani, yes, I would say, based on the rule that I told you, if somebody has a suspected subarachnoid hemorrhage, comes within time, do a scan in 6 hours, that is normal, then you discharge the patient because it's very, very, very unlikely for it to be subarachnoid hemorrhage. So I would accept B. I might also accept A because practically ඔයගොල්ලෝ වාට්ටුවල දකින්නේ සමහරට දැන් ලංකාවේ වැඩි කරන්නේ දැන් මෙහෙ නම් ඔය කොච්චර ඔය නීතිරියක් තිබ්බට උන් සාමාන්‍ය LP එකක් ගහලම තමයි යවන්නේ CT එකක් කරලා LP එකකුත් ගහලා තමයි යවන්නේ. So this is a sort of question where I can accept A or B as correct, right? So there are discussions we have when you are marking your papers. Do we award marks for 2 statements? B or A would be fine. And if they are validating, A and B, I can give you answers, true, correct answers for them. We talked about. Right. So what is the answer for this? So confused, right? මොකද්ද මේකට උත්තරේ and also the CSF findings ටිකක් දීලා තියෙනවා කියන්න බෑ. Herpes simplex නේද? That is clear cut. මේකට මොකද්ද උත්තරේ? So these are all atrial fibrillation තියෙනවා, right? And there are TIAs. So what would you do here? Slightly tricky, but my yeah. Nobody is committing any answers to this.
Anticoagulation.
Anticoagulation is the reasonable. I told you this. So if they have AF and develop TIAs, you can start anticoagulation on the next day or in 2 or 3 days, no problem. කොහොමද අපි warfarin දෙන්න නිසා ඔක දවස් 3ක් යනවානේ වැඩ කරන්න, so no problem, right? So, yeah, anticoagulation is the answer. Good. This, I think, is the last one. What is the diagnosis here? So, this is a patient who has given birth and then seizure and you see papilledema, drowsiness, and some cranial nerve palsy. Yeah. This is actually should be third nerve, maybe 6th nerve palsy, but that's okay. It's not a big problem. Yeah. What is the answer? So this is very typical in pregnancy, childbirth, headache, seizure, cranial nerve palsy, papilledema. Racism make yan, Praveen. කාගේට නමක් කියන්නද? already කියනවා.
Venous sinus thrombosis.
Yes, venous sinus thrombosis. Yes, this is a very typical presentation, textbook presentation of cerebral venous sinus thrombosis. Very good. Hari. Okay, that is it. Hari. හෙට යන්නේ පුළුවන් නේද ඔයගොල්ලෝට? ප්‍රශ්නයක් නැහැ නේද?
ඔව් සර් පුළුවන් සර්.
හරි. දැන් 20 වෙනි ඔයගොල්ලෝ විභාගේ දවස් 10යි. Right. Now, ඊගාවට මොකද කරන්න ඕන ඔයගොල්ලෝට? The neurology will finish off by Sunday, no problem. What do you want to do after that?
මට කට්ටිය අහන්න බැරි වුණා සර් මේ.
ඔව් දැන් අපි කරලා තියෙනවා කාඩියෝවැස්කුලර් කරා, රෙස්පිරේටරි කරා, GI කරා, liver කරා, renal කරා, endocrine කරා, neurology. දැන් ඉවරයින් තව දවස් දෙකකින්. ඒ ටික නේද?
Hematology ඔව් සර්.
Hematology තියෙනවා, rheumatology තියෙනවා. ඔව්.
Infectious.
Infections are පොඩ්ඩයි තියෙන. ඒකට වැඩි වෙලා යන්නේ නැහැ. Rheumatology, hematology, okay, right. Sorry, hematology. මම ඒ ටික දාන්නම් දැන් hematology papers ටික. හරි. ඕකේ. right. ඒතර
sir,
අපි මෙහෙම කරමු. ලබන සතියේ එක දිගට කරන්න පුළුවන් නේද? සතියේ මුල වගේ ඔය ටික දාලා ඉවර කරගමු. ඒතර උගන්ට වෙලා තියෙනනේ පාඩම් කරගන්න ටික.
ඔව් සර් මේක කට්ටිය පොඩ්ඩක් ඇහුවා අර ෆස්ට් වීක් එකේ මේ ෆස්ට් හාෆ් එකේ වගේ පොඩ්ඩක් ඉවර කරගන්න පුළුවන් නේද කියලා.
ඔව් ඒක තමයි කියන්නේ. ඒක තමයි කියන්නේ. මට ප්‍රශ්නේ තිබුණේ ගිය සතියේ මම දැන් මෙතන වැඩ තියෙනවා මම කට්ටි තුනකට පන්ති කරේ ඒකයි පොඩ්ඩක් අවුල් ගියේ මේ ඔයගොල්ලෝ දැන් එකක් මෙහෙම විභාගෙ දැන් උන්ගේ අද ඉවරයි. ඊට පස්සේ දැන් ඔයගොල්ලෝ ප්‍රොෆ් ගෲප් එක ඊට පස්සේ ඔයගොල්ලෝ දැන් මේ සතියේ ඔයගොල්ලන්ට ප්‍රයොරිටි දෙන්න. ඒ නිසා මේ මම දාන්න ඔක්කොම ටික ලබන සතියේ බදාදා වෙනකොට ඉවර කරලා දාන්න. බදාදා හරි ඔව් ඒ වගේ වෙනකොට ඉවර කරලා දාන්න.
හරි සර්. අපිට ඕන වෙලාවක් පුළුවන් සර්.
හරි. Okay. Right.